Good evening. Today the discussion is on proning in ECMO. Myself, Dr. Rajavardhan, consultant in Manipal Hospital, Sarjapur. So, as you know, that proning has got a wide variety of implications in ICU patients, especially in ARDS. We know that it has got a beneficial survival benefit in ARDS patients on mechanical ventilator culture. It has been further used nowadays in awake proning, especially in pneumonia patients or ARDS patients, as well as in ECMO patients. So today our topic of discussion is awake proning in ECMO. Proning in ECMO. So before understanding the proning, you should understand the concept why proning is important. Okay. So this is basically a graphical presentation of an ARDS lung. As you can see in the lung, there are three zones are there. Okay. Upper zone where lungs are normal. Okay. In the middle zone, lungs are kind of partially opening and partially collapsing. Whereas in at the bases, you know that they are not expanding at all. Typically, ARDS lungs looks like this. So this is a CT superimposition of the same lung. Okay, they can see in the top lungs alveoli are more or less okay. As you go bottom, there are areas where the alveoli doesn't expand at all, and there will be no gas, no air also in this alveoli. So normal tidal volume in a patient is 6 to 8 ml per kg. So in this baby lung, how much tidal volume is there? What is lung which is expanding? It is much less than that. Okay. So when such a small lung is there, you have to ventilate, you should be very careful. Okay, your tidal volume will no longer be 6 to 8. You want to be say 6 ml is protected, maybe you might have to come down on that. So definitely not going to be normal tidal volume for the baby lung. So next we'll talk about proning process, how it might help. So first thing is you should understand that whenever you discuss about something, you don't need evidence for that. So you should have a rational physiology to determine whether it will be successful. You have a rational physiology, you have a logic behind whatever you're doing. Eventually, you'll find a success. It may take time to find a success in these kind of patients. So here, when we discuss about the physiology of prone ventilation, I'll talk about two aspects. One is lung compression by the surrounding structures. Second is ventilation perfusion mismatch. What do you mean by surrounding structures? It is one is heart and mediastinal contents with the surrounding structure. Second one is abdominal contents are the surrounding structures to the. Then we look at the evidence of that. So when normal patient, when they're lying supine, you can see heart and mediastinal contents compress on the medial and posterior aspect of the lung. Okay. We can see that it compresses this medial posterior aspect of the lung, decreasing its capacity to expand, then limiting the lung expansion. Okay. What happens when you're in prone position? You can see lungs are more independent. The pressure on the lungs are less and they can expand better. Okay. So this is a patient, similar patient in supine position, especially under the effect of anesthesia or under sedation. As you can see here, there's a liver or any abdominal contents applying pressure on the posterior caudal aspect of the lung, limiting its expansion. Okay. What happens in prone position is it will be abdominal will be more free and abdominal contents will be that part of the and the pressure which is applied on the part of the lung will be less, letting it expand better. So second aspect we discussed was ventilation perfusion mismatch. You know, as already discussed, ventilation is better in the upper part of the lung. Okay. By way of gravity, perfusion is better in the basal part of the lung. So grossly there is a ventilation perfusion mismatch because the basal part of the lung is not expanding. So what happens when you do prone is most of the alveoli get opened up. Even the base and upper part will also be slightly opened up better. So because of that, the ventilation perfusion mismatch will decrease and then have a better oxygenation when you do proning. Shunt fraction will get decreased. So this is not a new concept actually, prone ventilation. It is first thought in the 1970s. Okay. Initially, a lot of observation studies or retrospective studies have found that there was a benefit. RCT started happening around 2000. Okay, animal studies had got benefit, but RCT started around 2000. And finally, we have one first successful RCT we had it in 2013, that is Perseverance trial, which had got a good mortality benefit. So it took a lot of time to understand how the proning works, which patients might have a better benefit with proning, how long we should do proning, and when we should do proning. So these are the questions which took some time, but it was answered eventually in 2013. So when you look at the systematic review, which is published in ATS in 2017, there was a subset of patients started from 2001 to 2013. As you can see, when you compile all the trials, there was a mortality benefit which favors prone, but it took a lot of time. So in these studies, when they further sub-analyzed, they found that wherever the studies they found lung protective ventilation, there was a mortality benefit was there. Okay, that is 12 or 6 ml per kg. Whereas in non-lung protective ventilation, there is no benefit. Next is duration of proning. When you see the studies where proning was done more than 12 hours has got a mortality benefit compared to studies which are done less than 12 hours of proning. So indicating that there are, to have a benefit of proning, you should have a certain things which should be clear. Okay, indication is there should be a moderate to severe ARDS. They should practice lung protective ventilation. Longer duration is better, especially more than 12 hours. Proning till lung parameters are better. Okay, there are a few things which are clear. So what they did is in Proseva, when they applied all these things, okay, they found out that there was a significant mortality benefit, which was 33% in supine group, whereas proning patients it was 16%, almost 50% reduction in the mortality. So indicating that proning definitely have a role in ARDS patient on ventilator. Okay, so we know that prone ventilation is moderate to severe has got a mortality benefit. Now the question we want to ask today is whether it has got a benefit in ECMO. Proning. So proning is not without a challenge. We know that ECMO has got a benefit in ARDS. So there are certain challenges. One is when you are proning, you need a village of people. Lots and lots of people are required. Okay. Second, it needs a lot of human resources. Second is cannula dislodgement is a very high possibility because we are moving the patient. Third is bleeding at a cannula insertion site. There might be fluctuation in the flows. Okay, there might be ETT occlusion because of the kinking moving and all. These are the things which are challenges. But we are living in an era where you can see ECMO patient playing a basketball. Okay, they will be taken outside and they're playing a basketball. You can say it's not in our country, there are a lot of resources and all. But this our patient is walking with ECMO. Okay, see, when patients are able to walk with ECMO, they are able to play basketball with ECMO. I think proning is difficult. It definitely has got challenges. I don't deny that. Here also a lot of people are required, but you can't say it's impossible. Nothing is impossible if you have a will. Okay, till now there have been 12 studies in the 30 studies in fact. 11 retrospective study, one was a prospective study. Well, after this, 3 were multi-center studies, remaining were single-center studies. Okay, so when you do the systematic meta-analysis of patient, these are all in systematic meta-analysis. We are looking at the studies who are retrospective, maybe prospective, but they are none of them are RCTs. Okay, when you look at the studies, definitely a few things are clear. One is the got oxygenation. When you look at 3 components, PO2, PF ratio, and driving pressures, they were significantly better in prone patients. So definitely these are beneficial. Then we look at the mortality. When you look at the mortality, there are parameters which indicate that these patients have some mortality benefit. Okay, prone patients have got mortality benefit. But and then it's a retrospective study. There will be a lot of biases. There will be a lot of confounding variables. So what they did is they did a pooled individual data analysis from 4 studies where they matched patient to patient and they made the confounding variable similar in both the groups. Okay. So in those 4 studies, they found out that the mortality benefit was quite significant. Okay. So when they individually studied this patient, what might have been the mortality benefit in this patient, they noted that most of the patients have an age of less than 50 years, especially successful patient, BMI of less than 30, SOFA score of more than 12. Actually, Zika patient might have benefited from proning. Okay, P by F ratio less than 60 before ECMO. These patients, some of these patients, those who are not undergone proning before ECMO has got benefit. I'm not sure how to explain this. Duration of mechanical ventilation less than 7 days. So these are the subset of patients who benefited from proning. So the mortality benefit was it was 39%, 6% in prone group, as well as 48% in supine group. So we know that proning has got beneficial effect. It has got an effect on the oxygenation. It has got effect on the driving pressure or that means compliance. So we need to know when we should do ECMO or proning. Sorry. So there have been studies studies of proning in ECMO. These are also retrospective studies only. In these studies, when they saw it, if they done proning early, less than 5 days, they got a significant mortality benefit compared to studies which are done late after 5 days. Okay. In this, see, you can see here, there was a reduction in compliance better in patients who underwent early proning compared to late proning, as well as the oxidation benefit was much better in early proning patient compared to the late proning. Okay. So now we have got that there is some mortality benefit is there, oxidation benefit is there. So now because we live in the era of COVID, maybe lived in the era of COVID, I don't know how to comment on that. So we look at the studies on proning in ECMO, proning in COVID-19 patients with ECMO. Okay. In this, when they did a study on this, they noticed that there was a more mortality in prone patients in COVID. Okay. And even uh, mortality was more and the successful winning was less in COVID patients in the prone. The logic might be COVID is not like other diseases. Okay. COVID has got an entirely different pathophysiology. The recruitability of the lungs might be less in COVID, that is one. And other possible hypothesis is a pulmonary vascular problem rather than lung problem per se in COVID, indicating that prone might not benefit in this patient. So definitely I'm not sure what is the reason. At this point of time, what I can say is proning may not be beneficial in COVID patient, especially in the context of ECMO. So when we had it data, then I decided to look at what is the data regarding non-ECMO patient, systematic meta-analysis. So in this patient, when we saw, it is prone ventilation in only COVID-19 patient. It is a systematic meta-analysis which is published in BJ. In this, they found that some oxygenation carbon dioxide benefit was there, but mortality benefit was not there in COVID patient when you do regular prone ventilation also. So coming to a conclusion, whether prone ventilation has got benefit in ARDS or not, especially in the context of COVID-19. So at this point of time, we know that there are certain patients which are going to benefit. One is uh, less than 50 years, if they have hypoxemia and ECMO. When if you do early proning in ECMO, BMI less than 30, so for more than 1, duration of mechanical ventilation before 7 days, and it may not be beneficial in COVID-19. Now, what we are searching for the answer is whether we have a Proseva moment in ECMO or not. Okay, we had a Proseva moment in ARDS, 50% of the we may not get that part of benefit, whether we'll have a good RCT which might benefit or not. So for that reason, they decided to do an RCT, which is known as PRO-ECMO trial, which was published this year, 2024. Okay, here basically what they did is they included 86 patients in pro group and 84 patients in supine group. When they look at the etiology of this patient, they noted that more than 90% of the patients are COVID patients. Okay, we desperately needed an RCT in ECMO, but it came at the cost that it was done in the peak COVID period. So most of the majority of the patients are COVID patients. So one more thing they did is in prone patient, once they decided to do prone, they put all patients on a prone for 4 days, at least 4 sessions of proning. Okay, and they used continuous neuromuscular blockade during proning, irrespective of what is the patient condition. So outcome on this is there's no difference in successful unit, there's no difference in the mortality. But one more aspect when you look at this is adverse events. When you look at the adverse events is more important. They look at that there's no difference in the adverse events in prone and supine group. In fact, it might be much less in prone group. Cardiac event was less, cardiac arrest was less, bleeding events were less, strokes were less. So indicating that there might be a possibility that proning is safer. And maybe I can't say it is beneficial in this context, but definitely it is safer. This study per se has a lot of methodological flaws. It's very difficult to comment on the survival benefit with respect to these studies. So, what I would say is, any patient who was on ECMO, we should first see whether the goals of oxygenation is met or not. If they're met, why you want to keep a patient on phone? Okay, in fact, you can awaken the patient, you can try to extubate or do tracheostomy as early as possible. Why you want to keep an ECMO just because you want to prone early prone? So look at the patient who might get benefit. If the goals are not met, you look at the other parameters. What is the etiology? Maybe COVID you may not consider. So you look at the other things is whether they'll benefit from ECMO proning is you do an ultrasound scan, you do a CT scan or EIT, electronic impedance tomography, look at whether they benefit or not, and then do prone ventilation, continue proning till the goals are met. Doing a study maybe in this way might have got more sense, more logic. Okay, you need to have a logic and physiology before doing any study, and this kind of studies might make more logic. So my take home message is definitely prone ventilation has a role, and it is safer as proven in the studies. There is improvement in PF ratio and compliance. It is beneficial. Definitely, I think that has got a survival benefit in the retrospective analysis. Maybe we should do more studies in non-COVID patients to get a further assessment. Definitely, it is useful in persistent hypoxemia. We need a well-planned RCT to do this. Okay. Thank you very much. Any questions? Any questions?
Hello. मेरे पर्सनल प्लान जिस नाम से सेव किया है उसका इसके से क्या चालू है इंजेक्शन